Hello and welcome to the third episode of our Heart Connection 2022 virtual webinar series. This month we've been discussing topics covering the connection between the heart and brain. My name is Becca Kalibas and I am the Education Director for Conquering CHD. I will be your host and moderator for today's webinar, Impacts of CHD on Neurodevelopment from Infancy to Adulthood. On today's episode, we welcome experts from Children's Hospital Colorado and Lurie Children's Hospital of Chicago. Dr. Kelly Wolf is a pediatric neuropsychologist and the director of the Heart Institute Neurodevelopmental Program at Children's Hospital Colorado and an assistant professor for the University of Colorado School of Medicine. She also serves as the co-vice chair of the Cardiac Neurodevelopmental Outcome Collaborative. Dr. Amy O'Connor is a pediatric cardiac intensivist in the Cardiac Intensive Care Unit and pediatric cardiologist in the Single Ventricle Center of Excellence at Ann and Robert H. Lurie Children's Hospital, a pediatric cardiologist in the NICU Cardiac Neurodevelopmental Program, and an assistant professor of pediatrics at Northwestern University Feinberg School of Medicine. Welcome, experts, and thanks for joining us. Before I turn things over to our panelists, a couple of housekeeping notes. Following the presentation, we will be answering questions submitted using the Q&A feature at the bottom of your screen, as well as those we've received via social media. If we don't get to your question live during the webinar or you have follow-up questions, please email us at info@conqueringchd.org. Our panelists will not address questions specific to your medical diagnoses, but will speak in generalities and provide relevant resources for families to learn more. As always, with the information learned, we encourage patients and families to discuss their specific concerns directly with their care team. With that, I will let Dr. Connor start us off.
Thank you so much, Becca. So I am going to talk about the impact of congenital heart disease on neurodevelopment. And I'm going to cover the fetal to infancy to early childhood. Next slide, please. So as far as an overview, I'm going to review the prevalence of neurodevelopmental impairment seen in children with congenital heart disease, discuss the fetal, perioperative, and postoperative factors which impact brain development, discuss the typical neurodevelopmental characteristics seen in patients with congenital heart disease, and discuss high-risk criteria for neurodevelopmental impairment in infants and children with CHD and the recommended screening. Next slide, please. So the toll of CHD. As you know, advances in surgical, interventional, and medical therapies have led to improved survival in congenital heart disease. But as you know, we still face early and late morbidities related to their care, including physical, psychosocial, and neurodevelopmental impairments. Next slide. This is a slide from Marino et al. Showing neurodevelopmental outcomes in children with congenital heart disease. Along the bottom is the severity of heart disease, and then the prevalence of neurodevelopmental impairment. So as your congenital heart disease is more severe, you're more likely to see neurodevelopmental impairment, which impacts, as you can see, a large majority of our patients with congenital heart disease, particularly in the moderate and severe group. And then in children with particular genetic syndromes, that risk is even greater. Next slide, please. So how does congenital heart disease impact the brain? So starting in the fetal period, reduced blood flow and oxygen content may impede brain maturation, particularly in fetuses with transposition of the great arteries and single ventricle physiology. We see in term neonates with congenital heart disease that there's a higher incidence of white matter injury, similar to that seen in premature infants. And this is before any surgeries or any ICU stay. The white matter is the nerve fibers that are important to connect different parts of the brain and allow for exchange of information. And this can impair motor and cognitive systems critical for development. Furthermore, these are the areas that are more vulnerable to injury, such as ischemia and hypoxia. So here is a head CT. The skull is on the outside, and those little arrows are pointing to the little white areas of white matter injury. So this is just an example of what you can see on a head CT in a child with congenital heart disease. Next slide. Common genetic syndromes are also seen in congenital heart disease and associated with developmental delay. So Alagille syndrome, Charge syndrome, Down syndrome or trisomy 21, DeGeorge, Jacobson, Noonan syndrome, Turner syndrome, Bacterl, and Williams are those with a high degree of congenital heart disease and developmental delay. So if your child or you're living with one of these genetic syndromes, you're even at a higher risk of having developmental delay and intellectual disability. Next slide, please. So perioperative factors. Neonatal cardiopulmonary bypass and deep hypothermic circulatory arrest. These are factors that are used to support vital organs during cardiac surgery, can cause emboli or blood clots to the brain and central nervous system. These are known as thrombotic strokes. We can also see a period of global ischemia, which is decreased oxygen to the brain, even though we try to use these protective factors to minimize the injury. Follow-up studies, including the Boston Circulatory Arrest Trial, suggest that substantial neurologic deficits are associated with circulatory arrest periods greater than 45 minutes. That's not the entire surgery, but the part where you're undergoing circulatory arrest. And so there's no established safe amount of circulatory arrest, but we know that children with longer circulatory arrest times are at higher risk of having a neurodevelopmental impairment. In anesthesia, it's controversial how much anesthesia impacts the developing brain, but we do know prolonged and repeated exposure to anesthesia can cause neurodevelopmental impairment. Next slide. So postoperative factors. Postoperative low cardiac output, where the blood pressures are low, sometimes the oxygen saturations are low, can cause inadequate perfusion to the brain and other organs. As I mentioned, strokes can be seen both from the operating room and postoperatively. Commonly, these are embolic or blood clots that travel from one part of the body, either in the heart. It could also be associated with a line that can travel to the brain, or hemorrhage or bleeds in the brain. Seizures can also be seen. They're not common after congenital heart disease, but particularly in neonates can be a manifestation of neurologic injury in the acute postoperative period, particularly if those seizures are difficult to control or frequent. And then the unexpected, the acute cardiovascular collapse. So children that have had cardiac arrest and or have had to be placed on ECMO, which is mobile heart-lung bypass, have increased risk of stroke, seizures, and neurodevelopmental impairment. This picture on the left is an MRI showing the vessels of the brain. And then where that arrow is pointing is actually where there is a stroke that's caused a complete occlusion of the middle cerebral artery. So this is an example of an embolic stroke that could be seen. We also know that prolonged hospitalization can impact neurodevelopmental impairment. You're not getting the usual stimuli when you're in bed and ill and being cared for in the ICU or hospital environment. Studies have shown that greater than 2 weeks is consistent with prolonged hospitalization and puts you at higher risk of neurodevelopmental impairment. We also know that the medications that your child needs can also cause side effects. So an example that's common in children with congenital heart disease is diuretics are associated with increased hearing loss, which can impair the development of speech. So that's why we recommend frequent audiologic examinations and can be a factor in your child's neurodevelopmental impairment. And then also any kind of post-operative complications. So risk of vocal cord paralysis leading to dysphagia, difficulty feeding, you may need thickened feeds or NG tube dependence. That can also impact the development of feeding and speech. Next slide, please. So what is the neurodevelopmental phenotype that we typically see in children with congenital heart disease? Usually these deficits are mild, so a mild cognitive impairment. This may appear as a child needing more help in school, needing an IEP. Mild and gross motor deficiencies can also be seen. Decreased visual construction and perception. Impaired communication skills and social interaction. decreased executive functioning, issues with attention and impulsivity, and we do also see an increased incidence of psychosocial maladjustment and mental health disorders, such as anxiety, depression, and PTSD. Next slide. So how might this look in the infant? It can appear as lower muscle tone, delayed achievement of milestones such as crawling, walking, talking, feeding issues, issues with fine motor, so reaching for toys with both hands, grasping objects, feeding themselves, and impaired social skills. Next slide. The HA has come out with a scientific statement, which is where there's a panel of experts that have come up with recommendations. So this one is on the neurodevelopmental outcomes in children and congenital heart disease and evaluation. It first came out in 2012, and this shows how important this is to both the American Heart Association and the congenital heart disease community. Next slide, please. So who are our high-risk patients for neurodevelopmental impairment? So infants who have required open heart surgery in the first year of life, infants with cyanotic heart lesions not requiring surgery during the neonatal period. So this can be lesions such as Epstein's, TET-PA-MAPCA, so tetralogy of Fallot with pulmonary atresia, and MAPCAs that hasn't had a surgery. Other conditions determined by your healthcare team that put you at higher risk, and then a combination of congenital heart disease and other certain high-risk comorbidities. Next slide, please. These high-risk comorbidities include prematurity, less than 37 weeks of age, gestation, developmental delay recognized in infancy, genetic abnormality or syndromes associated with developmental delay, such as those I discussed earlier, ECMO or ventricular assist device use, children or adults undergoing heart transplantation, history of needing CPR, prolonged hospitalization of greater than 2 weeks, perioperative seizures related to congenital heart disease surgery, and significant abnormalities on neuroimaging or microcephaly. Next slide. So what are the goals of neurodevelopmental and psychosocial assessment? So this is to diagnose and to treat. And we know that treating helps, and intervening early helps maximize long-term outcomes. It helps improve intelligence, academic achievement, independence, emotional functioning, family functioning, and helps promote resilience. Next slide. So what are the neurodevelopmental recommendations for patients as high risk? So heightened developmental surveillance in the primary medical home. So this can be through the pediatrician in coordination with your cardiologist, your neurologist, or your cardiac neurodevelopmental team. So this includes screening at 9 months, 18 months, 30 months, and 48 months. A referral for formal developmental evaluation, a referral to early intervention services or early childhood special education services prior to the confirmation of a specific developmental diagnosis. So getting your child involved in early intervention, regardless of whether there's any concerns at present, is especially important. And then periodic formal reevaluations for developmental delay. Once again, regardless of the level of concern, because it can be very difficult and very subtle to pick out, and this can evolve over time. So at a minimum, we recommend formal reevaluation at 16 to 24 months, 3 to 5 years of age, and then 11 to 12 years of age. And then referral of the patient and family for psychosocial support to help promote self-confidence and to deal with the impact of neurodevelopmental impairment on both the child and the family. Next slide, please. So what does the infant assessment consist of? So developmental history. So this is where you come in telling us what milestones your child has achieved. Growth, looking at their growth curves to see their length, their height, and their head circumference. A feeding history, a neuromotor examination by a health professional, and an audiologic examination. Next slide, please. and then the toddler assessment. So we'll typically use a standardized developmental measure to help categorize, so using the Bailey-3 or some other testing, and then a behavior parent report using some kind of questionnaire. Next slide. And treatment. So this is going to be very specifically tailored to your child with the coordination of your healthcare team. So it may include additional services such as physical therapy, occupational therapy, speech and language, and developmental therapies through either early intervention, through private services, or through the medical center. It's especially important to stay connected with your medical center cardiac neurodevelopmental clinic. So hopefully you have one available through your medical center, or there's one in your city to help continue to kind of watch closely and help coordinate care. And then as a parent, if you have concerns, even if they're subtle, we want you to notify your child's physician so that they can make the appropriate referral if necessary. Next slide. So this is a slide just showing the brain across a lifespan. And we've covered both the perinatal brain and covering that injury and dysmaturation can occur in the developing brain of children with congenital heart disease. So this can be due to hypoxia and ischemia, epigenetic factors, so the environmental factors, even your placental factors, and then genetic syndromes. And then we've started to talk about the infant. So white matter injury that can happen through surgery, through the post-operative necessary care, and then also the complexity of the child. So now I'm going to hand it over to Dr. Kelly Wolf, who's going to cover the early childhood and adult. Thank you.
All right, thank you so much, Dr. O'Connor, for that introduction. So I am going to take the baton from where Dr. O'Connor left off and talk about brain development and cognition in children with CHD from school age all the way through adulthood. Next slide, please. And so a brief overview of what I will touch on is first to go through some of the brain imaging research in adolescents and adults with complex CHD, most of whom meet the criteria that Dr. O'Connor presented earlier for AHA high-risk criteria. And then I will discuss a little bit more about that neurocognitive or neuropsychological phenotype, which means just like the typical profile that we tend to see of strengths and difficulties in adolescents and adults with complex CHD. Next slide, please. Thank you. So what we know is that some of the research that Dr. O'Connor presented already about brain differences in development in the kind of the fetal and infancy period, we see that those differences continue through adolescence and even into adulthood for people with CHD. So this was one of the earlier neuroimaging studies in adolescents with complex CHD, reporting on 39 teens who underwent surgery with bypass during the first 5 years of life and had brain imaging done when they were 11 to 16 years old. The big take-home point here is that their brains were still smaller in volume compared to heart-healthy peers. And this graph shows, it kind of breaks down every different kind of little structure or aspect of the brain and shows that across almost all of them, everything with a star next to it was significantly smaller in the brains of adolescents with complex CHD. Next slide, please. In addition, total brain volume was predictive of kind of overall cognitive skills or IQ in the CHD groups, both looking at cyanotic CHD, which means a type of CHD that impacts the amount of oxygen in the blood, versus acyanotic CHD, which means CHD but pretty normal oxygen levels. So those lines demonstrate that there's a positive correlation, meaning higher brain volumes was related to higher IQ in both of the CHD groups. This relationship did not exist in heart-healthy controls, and just in general, kind of in child development literature, there's not usually an association between brain size and IQ, again, in people who are heart-healthy. So that demonstrates that the decreased kind of brain growth is directly related to the neurodevelopmental outcomes, again, even in adolescence, so past that early infancy period for people with complex CHD. Next slide, please. This is the largest study of brain imaging in adolescents who have undergone the Fontan procedure for single ventricle physiology palliation. So they did brain MRI as well as neuropsych testing. Next slide, please. Yeah, and so kind of the big take-home points here were that about 66%, so 2 in 3, had some type of abnormality on brain MRI. Again, this was done for research purposes. In many, if not most centers, brain MRIs are not standard of care, you know, kind of in adolescence to check for these sorts of things. And in many cases might not change care drastically either. Focal infarction or atrophy, which is the third line down. So in about 13%, there were signs of stroke. That was 19 children, and in a little over half of those, that was undiagnosed before the research study, just kind of demonstrating that there's probably increased rates of stroke that may not be clinically detected in our Fontan population as well. Next slide, please. Further brain MRI studies have looked at the white matter integrity. So Dr. O'Connor presented about how white matter can be particularly impacted by CHD. And white matter continues to develop until our late 20s, whether you are heart healthy or have CHD. And so sometimes these studies later in adolescence or adulthood can really show us some of the longer term impacts of CHD on white matter. So this study looked at almost 50 teenagers with transposition of the great arteries and demonstrated relationships between white matter damage in several different areas of the brain with neuropsych functions that are typically associated with those areas. So in the left parietal lobe, which is that kind of blue area in the back portion of the brain, damage there was related to poorer math achievement and increased inattention or hyperactivity symptoms in this group. Lower white matter integrity in the right precentral area, which is kind of that orange frontal lobe, or this is my right side over here, was related to increased inattention and hyperactivity symptoms and more difficulty with executive functioning, which are things like planning, problem solving, and organizing. More broadly in the right frontal lobe, white matter damage there was associated with poor visual spatial skills. And the internal capsule, which is very deep in kind of the center of the brain and is involved in a lot of connections between different parts of the cortex, poor white matter integrity there was associated with more memory difficulties in this population. So kind of making that link between white matter integrity in different parts of the brain and those neurodevelopmental or neuropsychological outcomes in teenagers with complex CHD. Next slide, please. So moving into adulthood, we see some combined effects of kind of the reduced blood and oxygen delivery to the brain over time, increased inflammation that can be a cascade from that, and then higher rates of acquired cardiovascular disease. So adults with CHD are especially vulnerable to kind of cardiovascular disease that we tend to think of as happening in older populations, and that's why we call it acquired. So things like atrial fibrillation, tachycardia, hypertension, disorders of glucose metabolism, coronary artery disease, and even kind of progressing towards heart failure or at least reduced cardiac output. Next slide, please. And we know that in heart healthy populations, heart failure or reduced ejection fraction is associated with a higher risk for developing cognitive impairments consistent with Alzheimer's disease or other dementias, as well as just more broadly executive functioning difficulties. And those are, again, those skills like planning, problem solving, and organizing. As well as heart failure is linked to just white matter differences and smaller total brain volume, again, even in people who are heart healthy. Atrial fibrillation is associated with an increased risk for cognitive impairment and dementia in aging populations as well, with an odds ratio of 2.3. That means if you have AFib, you are 2.3 times more likely to develop some of those cognitive symptoms than someone who does not have AFib. And coronary artery disease is also associated with a higher risk for vascular dementia and Alzheimer's disease. And so when we think about these risks with these kind of acquired cardiovascular factors, we are kind of layering them on with an already vulnerable brain for the individual with complex CHD, which makes kind of neurodevelopmental monitoring and proactive intervention even more important. Next slide, please. In terms of the research looking at brain development in adults with critical CHD, we essentially see kind of continuations of what's been presented already, which is reduced gray matter and white matter volumes. So brains continue to be smaller even into adulthood. And the cortex, which is the outer layer of the brain that kind of folds into sulci and gyri, is less thick. in adults with CHD as well. Next slide, please. So switching to kind of the neurodevelopmental or neuropsychological testing research that's been done, kind of what are the consequences of these different brain structural abnormalities for adolescents and adults with critical CHD. So in terms of overall IQ, the literature is pretty variable depending on the specific CHD populations included. In general, more severe types of congenital heart disease can be linked to lower IQ. And when you look at this kind of bell curve that I presented here, some of the scores that will be presented from the research, a score of 100 is exactly in the middle for the general population. An 85 to 115 is kind of one standard deviation in either direction. So taking us back to statistics class here a little bit, about 2/3 of the population will fall within that 85 to 115 range in the blue parts. And then you can see kind of fewer and fewer people will fall into each range the farther away you get from 100. And so, for example, as a population as a whole, kiddos with single ventricle heart disease or a heart transplant generally have an average IQ, not of 100, but of 85. But again, with distribution around both sides of that number. And so, and also with some nuances such that nonverbal or kind of visual spatial reasoning skills tend to be a little lower in our CHD population compared to verbal reasoning skills. Next slide. Thank you. Some of the downstream consequences of those kind of cognitive and neurodevelopmental difficulties can include academic learning. So in some previous research has shown that over 1/3 of children with HLHS in one study were receiving special education services. And I thought it was pretty notable that that was back in the year 2000. And I think that the field has come a long way in terms of recognizing the neurodevelopmental consequences of HLHS since then. In another study in 2008, about half of school-age children with complex CHD reported receiving some kind of remedial education supports. And in a subset of children with HLHS, their kind of median math and reading scores were right about that 85 range, so about one standard deviation below the mean. Although, as you can see, a really wide range in both groups, underscoring the importance that even though we speak in generalities about populations as a whole, it's really important to kind of have that individual evaluation to see where one person may measure in these different areas. And in another study that looked at 60 children with transposition of the great arteries, about 18% reported having impairment in some school difficulties, just on a self-report questionnaire. Next slide. In terms of language, receptive language, which means what we understand, and expressive language, which means what we are able to say, tend to be areas of relative strength in school-age adolescents and adults with complex CHD. However, there certainly are a subset of the population, especially in younger ages, that can have some of those speech language delays, such as apraxia of speech, which means trouble with oral, motor, kind of muscle coordination, which can result in articulation difficulties, which has been reported specifically in transposition of the great arteries. And then a few studies have also shown that some of the more complex aspects of language, such as pragmatics, like reading social cues, and some of the academic aspects, like phonological skills, can be more difficult for children with complex CHD as well. Next slide, please. Visual, spatial, and visual motor skills tend to be challenging for kiddos with CHD. This is a little bit of a continuation of some of those early like fine motor delays that Dr. O'Connor mentioned, and can impact handwriting skill development. So about 1/4 to 1/2 of school-age children or adolescents with complex CHD will have kind of continued fine motor difficulties. And again, as with other areas, this tends to vary kind of in relationship or proportion to the severity of the congenital heart disease and or kind of comorbid or other conditions. Next slide, please. In terms of memory, not much research has looked at memory specifically in complex CHD. One study looked at 40 school-age patients with HLHS and found verbal and visual memory to be poorer just compared to heart-healthy controls. They were looking at different protection strategies used during bypass, including anterior grade cerebral perfusion versus deep hyperthermic circulatory arrest, and found no difference in kind of which bypass strategy was used on later memory skills. Another smaller study looked at 17 patients with single ventricle physiology, and again found kind of poorer verbal and visual memory compared to controls or patients with two ventricle heart disease. Next slide. Attention is probably one of the most common areas of difficulty that we see, especially in kind of school age, adolescent, and adult individuals with CHD. Research pretty consistently shows that about 1 in 3 people with Fontan physiology and/or those who undergo heart transplant will end up kind of having clinically significant or diagnosis of ADD or ADHD. In one study that looked at comparing children with CHD with their sibling controls, it found that either transposition or tetralogy of Fallot patients tended to have more ADHD symptoms compared to their siblings. And in general, kind of children with complex CHD were 3 to 4 times more likely to have clinically significant hyperactivity scores on parent rating scales. Next slide, please. Executive functioning is a term, an umbrella term that talks about skills such as planning, organizing, and problem solving. And so this is, again, one of the more common areas in a very large study that looked at almost 470 children and teenagers aged 10 to 19 with different types of complex CHD. We found that the average scores for the CHD groups on executive functioning tasks, they still tended to be in that average range on the bell curve, the blue, but they were lower than kind of matched control group. And rates of impairment or clinically significant difficulty was twice as high as expected, particularly in the tetralogy Fallot and single ventricle group, and slightly less so in the transposition of the great arteries group. And similarly with kind of skills like processing speed, which is cognitive efficiency, or working memory, which is like that very short-term memory piece. Difficulties have been noted across CHD groups and age ranges with kind of medium to large effect sizes in both of these areas. Next slide, please. So in adulthood, these neurocognitive difficulties that I've described in different areas certainly can extend and kind of continue into adulthood and tend to affect things like independence and social outcomes more than, academics per se at that age. So less research has been done in adults with CHD, but in one study that looked at 48 adults with moderate or severe CHD, they found kind of continuation of that neurocognitive profile where adults with severe CHD had poor attention, executive functioning, and processing speed compared to controls. Although those with moderate severity CHD did not show cognitive differences from heart healthy controls. More broadly, we know that adults with CHD are at risk for lower educational attainment, underemployment, which means, being employed perhaps more likely to be part-time than full-time, delayed progression into independence in adulthood, and also increased risk for anxiety and depression. And those risks are 3 to 4 times higher in those individuals that also have some sort of neurocognitive impairment. So the cognitive and the anxiety and depression symptoms are really interlinked for adults with CHD. Next slide, please. All right. So I hope that it has been informational and helpful to hear, kind of raise awareness about all the difficulties in neurocognitive skills that can come along with congenital heart disease. For families or individuals that may be experiencing these, I hope you hear that these are real. They are not things that you are imagining or, making up problems where they don't exist. We have a lot of very good science to say that kind of the risks of for brain functioning associated with complex congenital heart disease. And these extend from the fetal period into adulthood and beyond. And much of our research is still following cohorts, especially of people with complex CHD as they age to find out more about what that looks like. Next slide, please. And finally, I just want to say, I know we didn't talk a lot about interventions or accommodations here, and I don't mean to be doom and gloom by just going over the research about the difficulties. There are a lot of interventions, accommodations, and supports for brain health and neurodevelopment at every stage. I want to point out that our webinar that we did with Conquering CHD last Friday went over a lot of the ways to get accommodations and supports in the school system, including into higher education and on the job. So I would encourage you to go back and watch that webinar if you have questions about those aspects. As Dr. O'Connor mentioned, always encourage you to contact your Heart Institute's neurodevelopmental program for evaluation and treatment options. And a lot of the science is coming out of people associated with the CNOC, the Cardiac Neurodevelopmental Outcome Collaborative, who are working on revamping their website to be more kind of patient and family friendly in terms of research summaries, abstracts, and kind of a repository of resources around neurodevelopment. So I want to put that website on your radar as well. And I think that is my last slide. So thank you very much for having me, and look forward to your questions.
Thank you both for that incredibly informative presentations. At this point, we will open it up to questions from our audience. As a reminder, you can submit your questions through the Zoom chat or using the Zoom Q&A feature at the bottom of your screen. We got a couple of questions while you guys were talking, so I'll start with the first one. Courtney asks, what is the incident rate of developmental impairment after being on bypass for greater than 45 minutes?
That's a great question. Amy, I don't know if you have any thoughts on this one. I am fairly confident we don't have the research to answer that one specifically. In general, bypass time is one of the, 15 to 20 risk factors that we tend to think of as when you have longer bypass time, you have a higher risk for neurodevelopmental impairment. But there are so many other factors that have been shown to kind of explain more of the variability in neurodevelopmental outcomes than surgical strategies. In addition, it's difficult because kids who require longer bypass time tend to have more complex cardiac conditions or perhaps like surgical complications. And those things in and of themselves carry risk for neurodevelopmental impairment, if that makes sense. So it's difficult to say how much is the actual time on bypass versus the complexity of the condition that requires a longer time on bypass. So I'm sorry that I don't have a good answer for that question. But overall, I think that most research points to things like complexity of the congenital heart disease itself, as well as some of our social determinants of health research coming out as being some of the strongest predictors of neurodevelopmental outcomes for people with CHD.
Amy, did you have anything to add?
Yeah, so tag on to that. So most of those studies about circulatory arrest and bypass originated at Boston. And so those started in the 80s and 90s. So we know that our techniques have certainly improved now in the year 2022. But I believe it was 20 to 30%. And that was specifically in transposition of the great arteries. And as Dr. Wolf mentioned, we know it's one of the factors and not the only factor that can make someone high risk. And certainly the longer you're on bypass or circulatory arrest usually means that you have more complex surgery, which also puts you at higher risk of having postoperative complications and longer hospital stay. So it kind of is all intertwined, but great question.
Thank you. Anya asks, can this research be used to advocate for coordinated care or IEPs when heart kids don't meet the typical criteria for services?
Yeah, thank you, Anya. That's a great question. So what I have been able to advocate for in the past, and I would encourage you to watch the webinar from last Friday because we had some really excellent points by experts, former teachers, and educational liaisons that know much more about the school system than I do. Sometimes we are able to, it's always helpful to discuss the risks for neurodevelopmental difficulties with school teams. Sometimes from a legal perspective, even if a kiddo doesn't qualify for a full IEP based on the criteria they've set out, schools can have kind of a lower threshold for intervening and setting up an IEP rather than like a wait to see or a response to intervention approach for kids with CHD. One of the strategies recommended by Kyle, the educational liaison last Friday, was to develop a health plan, which schools will always give to a kid with complex CHD, and to put in the health plan a lot of information about neurodevelopmental symptoms or consequences of their heart condition. And that can be a good way to have it documented and have the school watching more closely. Again, just to be able to intervene and start that like IEP or more formal services at the slightest kind of indication of any difficulty.
Along that line, Anya also asks, are there any preventative steps that can be taken to anticipate or compensate for some of those cognitive defects frequently seen in heart patients?
Go ahead, Amy.
Oh, I don't know if it's preemptive, but certainly we recommend even in our infants immediately getting your child with congenital heart disease into early intervention, even if you don't see any concerns, because just having them in the house working with the infant or doing virtually nowadays, we know can help. So I don't know if it's preemptive or preventative, but certainly we recommend having those coordinated OT-PT speech, even if there aren't any differences detected yet.
Yeah, thank you, Amy. And I would just piggyback on that to say that in school age years, kind of keeping in really close contact with teachers about any attention or learning difficulties, especially that might be noticed, because at the first sign of those, there are interventions that can be done to kind of help course correct. There's really good evidence-based research-backed interventions, especially for like reading or literacy difficulties. There's good curriculums for math intervention, for attention or executive functioning difficulties. There are some different kind of cognitive training approaches, as well as consideration of medication for attention in some cases. And so those are all ways to kind of try and course correct and get back on track. In terms of prevention, I think things that we just generally recommend for brain health are just to be active and live a healthy lifestyle, but there's not really any therapy or treatments that we know of that we know to be effective in preventing some of these developmental difficulties. More just kind of close monitoring and proactive intervention whenever any signs of difficulty arise.
Great, thank you.
Okay.
Heather asks, what would your recommendation be if the state you live in does not have a neurodevelopmental clinic? Would you recommend going out of state or find a team of doctors in your state that may be able to help?
Such a good question. I guess that is a little bit of a different question for each family, or a different answer for each family, I would say, depending on what works for you and how concerned you are about neurodevelopment. I think starting with your cardiologist and or your pediatrician is a really good way to start. They may know of some resources. Most states have like developmental psychologists or pediatric neuropsychologists, like in private practice, for example, but the degree to which they may be familiar with CHD and the neurodevelopmental consequences may be pretty variable. You could always reach out to someplace like CNOC or your child's heart surgery center to ask if they have any referrals in your area, because you might not be the first person to wonder about this from your center. And, you know, maybe there is a neuropsychologist like in private practice that has had some conversations with, those at your heart surgery center and is, maybe a little more up to date on the research. But I will say that especially in school age and beyond, neuropsych evaluations are really only recommended maybe once every 3 years, sometimes longer. So if travel is realistic for you, or if you have family in an area that has a cardiac neurodevelopmental program and it makes sense for you to go, it might not be too onerous to kind of go once every few years for that really comprehensive checkup. So kind of a non-answer, but just a lot of different possible options. I don't know, Dr. O'Connor, if you have other ideas there.
No, I think very similar to what you said. CNOC is a great resource, and then also working with your medical team. Sometimes there are resources for younger infants through the NICU population that may not be specifically tailored to the congenital heart disease population, but that may be one area or resource you can tap into if there isn't a specific cardiac neurodevelopmental clinic, or in some of the private neurology, neuropsychology groups. So starting with your primary cardiologist, I would recommend.
Thank you for that. Katie asks, would you speak to evolving research and recovery of all that lost potential? As a parent, I've found lots of research about the negative impact, but very little about how much potential may be recoverable. How is that conversation and work evolving? It's a great question, Katie.
Do you want to go? I can go.
Doesn't matter. So that's a really good question, and certainly that's why we preach early, intervening early and getting the interventions, because we do see that it works. For those of us that follow these children, we see improvement in their school and academic achievement, their self-esteem, mood problems. But as far as actually measuring that with research, it's a little difficult to, so I don't know of any research that specifically follows that, but it's a great question.
Yeah, I would agree, Dr. O'Connor. It's almost impossible to measure the effects of it, because to do that, we would have to assign some groups of children to not receive intervention, which we would just never do, right? And so I think that, and I think it depends a lot. We talk about neurodevelopmental difficulties as a whole, but there are some things like for example, dyslexia or ADHD that have very clear research-based treatments. And even if your ADHD or dyslexia we think is related to your congenital heart disease, we still recommend the same types of therapies and treatments as we do for heart healthy children who are just born going to have those developmental difficulties. So we can kind of piggyback off of decades of neurodevelopmental intervention research in those areas. But there are other areas like the lower overall IQ or increased intellectual disability incidence in congenital heart disease that we really don't have interventions for. We kind of do more supports and we work to increase independence and kind of functional skills in day-to-day life. So it really kind of depends on the area that we're talking about as well in terms of the neurodevelopmental difficulties and kind of what other intervention research in the broader child psychology field that we can kind of leverage to support neurodevelopment in those with CHD as well.
Great, thank you. A couple of questions we've seen a lot coming up on our social media platforms and questions just from people who follow us. Primarily adults who feel like they're kind of stuck with some of their skills. They're maybe not as mature or more developed, especially mentally or just life in general, than their peers their age. Do you feel like there's a lot of adults with CHD that feel that way or have concerns about that?
Yeah, absolutely. Especially those, I see that mostly or much of the time in those with more complex CHD. So especially our kind of single ventricle Fontan population as well. So I would definitely want those people to know that they are not alone. I think starting by talking with your cardiologist can be a good place to start. Sometimes adult cardiologists are a little bit less attuned to the neurodevelopmental consequences of CHD. I think that they're more slowly or, kind of being exposed to that a little more gradually than maybe the pediatric congenital cardiologists. But I know at our center, we partner with the adult neuropsychology clinic at the university hospital. So even our adults with CHD can get neuropsych evaluations that can be helpful in kind of pinpointing the exact area of difficulty. For example, a lot of adults with CHD tell me they feel forgetful, which impacts their ability to finish school and get a job and kind of manage their care. But testing can show whether that is an actual memory difficulty versus executive functioning, which is that planning and problem solving. And the interventions or supports we would recommend are very different depending on if it's a true memory difficulty versus executive functioning. So that can be a nice place to start in terms of looking for interventions and supports. And more broadly, if there's not an adult neuropsychology clinic available, working with a psychologist, a counselor, a licensed mental health professional on kind of strategies for kind of not just mental health, but also kind of planning, organizing, becoming more functional and independent. Those are all things that a licensed mental health professional can work on. I think most people think of like lying on a couch and doing talk therapy, which certainly can happen as well. But you can have kind of more structured or functional goals and for therapy. Absolutely.
Dr. O'Connor, anything to add there?
Thank you. I think Dr. Wolf covered all of it.
Great. So we have about 10 minutes left, and I have kind of a final question to both panelists, maybe not a question, but any last advice you have for parents, for patients living with CHD, both teen and adult, kind of struggling with some of those neurodevelopment issues? Any last advice for them as we close out?
So I would say it's difficult and hang in there. Confide in the medical professionals that you trust. Hopefully you have a team that you feel that you can share these difficulties with, and know that you're not alone and that there are others with congenital heart disease or acquired heart disease that are having similar struggles, so that we can help you and make the referrals necessary and help achieve your goals and really thrive. Or what I would say.
I totally agree with Dr. O'Connor, and I would just add to that it's really important to keep a balanced view of our weaknesses with our strengths. I know I talked about this last week as well, but we tend to really focus on deficits and impairments and what we can do to rectify those, and that can be really important. But also keep in mind that everyone has strengths and things that they are good at, things that they're naturals at, and those really kind of tend to determine more of our long-term path. We all gravitate towards activities and interests and careers that play to our strengths. And so to not neglect kind of investing time and effort into your or your child's areas of strength as well, and use the accommodations and supports that they can qualify for through like the Section 504 of the Rehabilitation Act and special education law. Make sure to use accommodations and supports that they qualify for based on their medical history to kind of support the weaknesses so that the strengths can shine.
I think that is great advice from both of you and a great place to end our afternoon. As Dr. Wolf mentioned, we have a couple of previous webinars from this topic covering prenatal factors impacting development, and also the K through 12 education kind of IEP 504 conversation we had last week. So be on the lookout for those on our website. Thank you so much to our panelists again for sharing your expertise and thoughtfully addressing the questions from the audience. We appreciate your partnership in educating our patients with CHD and their families. And thank you to our audience for joining us as well. We would like to thank our Heart Connection 2022 sponsors. Your generous support enables us to bring crucial educational programming like this to patients with CHD and their families when and where they need it most. For more information on the Heart Connection virtual webinar series, including upcoming topics, or to submit follow-up questions, please visit us at our website. If you would like to support more programs like this one, please visit our website or scan the QR code on your screen to donate. Join us throughout July for the next topic in our webinar series, Step Up and Thrive, covering topics related to transition from pediatric to adult CHD care. Check out our website for more information. We hope you'll join us next time. Have a great afternoon.